when a physician's using this device for IVUS reasons and encounters a large lipid core plaque, that physician now has more information than they would have had in the past about what's going to happen.
Right, correct. I mean, this is, I think, has evolved into what's becoming the best-in-class IVUS instrument. It's a beautiful grayscale IVUS with what is now, I think, the standard for composition detection in an IVUS-type catheter. What to do with data that we obtain in patients and how to apply it in an individual patient when you're in the cath lab trying to help somebody is an issue that we have dealt with throughout modern medicine, which is that we now have guidelines for all kinds of things, and we have regulations and cost issues, and yet where the rubber meets the road is when you're taking care of a patient, whether it's in the cath lab or coronary care unit or in your office. You're always having to make decisions with incomplete data. You say, all right, I understand this about an individual patient. I now have this data, and the need for future studies and more data is always going to be there. But yet you still have to make decisions in patients now. We make them all the time and have been for the past 30 years. When you see a lesion in the cath lab and you're going to stent it, do I stent it this long or do I stent it this long? Do I treat the patient with surgery or do I treat the patient with stenting or medical therapy? And there's no simple button you push and the right answer comes up, and that's why physicians still play a role. We take our art and our skill and the science and the data and try to make the best judgment. So now we have this exciting data coming out of this instrument. The IVUS data is extremely helpful, I think, in many situations, which IVUS is already well established. The compositional component from the NIRS spectroscopy is, I think, very exciting and powerful. Precisely how that will influence decisions, I think, is something that's going to have to evolve over the next couple of years. Are we yet at the paradigm when we can begin to attack this vulnerable plaque issue? Because the question that I deal with my patients all the time is they've come in with an event, I fixed their flow-limiting lesion, they've done fine. They come back to see me in the office and they say, "Doc, thanks for taking care of me. I'm feeling much better, and I'm really kind of worried. Now that you fixed that critical narrowing, the stent, I'm not going to never have another heart attack, am I? I'm not going to die.
What do you say?
Am I?
What do you say?
I say, well, here's the problem. You're doing great, and we were going to control your blood pressure and have you exercise and take the right medications to lower your cholesterol and antiplatelet drugs and all the things that we consider standard established therapy." And then the patient will say, "Well, I'm going to do all that, but I'm not going to have another heart attack, am I?" I say, "Well," and the well is that over time there's still a risk, not a trivial risk, of another event, an MI or a sudden cardiac death. As we know, they commonly evolve from non-flow limiting lesions that can be sudden, abrupt, unheralded by any symptoms, and quite calamitous. And so that is the vulnerable plaque issue that started this technology. And let me ask you the question, where are we with studies beyond the landmark prospect study that you described that Greg Stone and his colleagues published, that I think really moved the field forward in validating the concept that you could prospectively detect lesions that were at risk for events, which then naturally leads to the question will this become routine practice to perform multivessel scanning with one kind of instrument or another? What would that instrument look like? Where are we with trials at actually taking such lesions as described in the prospect type lesions and actually doing a therapeutic trial of either medical therapies that are novel or a preemptive stent?
Yeah. So that's a lot of questions, and I'll start with the first one. Where are we right now? Fortunately, you've contributed, and many others have contributed to the color registry. So we have 800 patients under surveillance who've had a cath and now have a chemogram of that artery. And we're waiting to see what happens at the sites that have yellow. Unfortunately, we predict that there are going to be more heart attacks there. And we've had a couple cases now where yellow turns out to be bad for long-term outcome. And then we've had the converse. We have a lot of red chemograms, no lipid, turns out to be very good. We're not seeing any events in those patients. So when you mention the patient who says to you, doctor, is this going to happen again? Generally, when I was treating patients, I used to spend a lot of time saying, well, you've got your lipids where they need to be and things are looking good, your diet's better, and your cholesterol is low in your blood. I think it's going to be very nice to be able to say to a patient, your cholesterol is low in your blood and it's low in the wall of the coronary artery. So that what might well be a much more powerful predictor of the future.